Okay, so Cheyenne, would you like to go ahead and share your screen?
Good morning, everybody.
Good morning.
My name is Sandra, and we have Jason here too.
Good morning, everyone.
My voice is going, so I'm warning everybody, if I disappear altogether, Jason will be taking over on the PTOT part as well. So we're just going to have to bear with me for a little bit. So this morning we were going to talk about a comprehensive approach with regards to how Huntington's disease patients, exploring some of the interdisciplinary rehab team, and how we can work with you as a coaches long term. And so some of the goals of this presentation, what we're wanting to do is describe the essential elements of what Huntington's is through the definitions, identifying the stages of Huntington's, defining the goals of what the therapy will do, identifying interventions with regards to the therapist, both PT, OT, and speech, will employ, and then name and describes some of the use of frequently used devices and equipment that we may recommend that may be useful down the line at different stages, and then demonstrate an understanding of the role of the interdisciplinary team. So next, we want to just introduce everybody to the actual team. They always say it takes a village, and so this is kind of our little village here in Houston. Everybody's very familiar when they come in, as Dr. Fersman has said many times. This is almost like a little smorgasbord. We come in and you meet a little bit of everybody and get a little taste of everything. So today, from a therapy standpoint, we're wanting to kind of give a little idea of what PT, OT, and speech do, and we're going to kind of give a little bit of definition of each, and therefore give you why we approach the way we do. With regards to physical therapy, the World Physical Therapy definition, physical therapy is concerned with identifying and maximizing the quality of life, movement potential within a sphere of promotion, prevention, treatment, intervention, habilitation, and rehabilitation. With regards to occupational therapy is a client-centered health profession concerned with promoting health and well-being through occupation. The primary goal of the occupational therapist is to enable the people to participate in the activities of everyday life. So with regards to physical therapy and occupational therapy, I'm going to address that, and then Jason's going to jump in with speech. From a physical therapy standpoint and occupational therapy standpoint, we have the potential to improve the Huntington's patient and their family's quality of life by working towards improving their movement and their abilities to keep them as independent as possible, preferably for as long as possible, so that they can have that quality of life. So Huntington's disease is a hereditary, as you know, neurodegenerative illness with physical, cognitive, and emotional symptoms. The distinction of the Huntington's disease is the presentation of difficulty with involuntary movements, such as reflexes. Another of our involuntary movements, such as gait or walking. And then with regards to the types of different movements that you'll see is the akathisias, such as a state of agitation or distress and restlessness. You have the dystonia, which is abnormal muscle tone, resulting in muscle spasms and abnormal postures. You have chorea, which is the jerking, involuntary, or dancing type movements, affecting especially shoulders, hips, face, legs, limbs. The achonesias, such as loss of impairment of involuntary activity as of a muscle, such as a slowness or difficulty initiating that movement. Next, you have bradykinesia, which is a very slow movement, and sometimes that initiation of movement are very slow, almost rigidity with regards to the movement. And then you have the force control, which is difficulty controlling the force of the movement, making those small movements and creating big outbursts because they emphasize that control or movement. Then you have the uncoordinated movements, such as the loss of motor control, often leading to repetitive rhythmic movements as well. So with regards to Huntington's disease news, although the exercises recommended for Huntington's patients train different areas of the body, all aim to reduce or try to eliminate falls, promote normalizing walking and body control, build coordination, and encourage a positive and confident attitude towards the body. The goal is to try to make them as smooth or as normalized to movements as possible to let them be able to continue with their activities of daily living as best they can. So the intervention of physical therapy and occupational therapy in the Huntington's disease depends on the stage of the disease as to where we would be most likely to be needed. And at the different stages, we're going to talk about that now as to when we would be jumping in and when we are going to be most effective. So in the early stages of Huntington's, individuals are largely functional and may continue to work, drive, handle money, live independently. Symptoms may include minor involuntary movements such as chorea, subtle loss of coordination, or difficulty thinking through complex problems, and perhaps possibly some depression, maybe some irritability or inhibition. With regards to the early stages, other physical symptoms that you may start to show would be slowing of movement and occasional balance loss, to where the patient may be tripping. You may see them having more clumsiness and things like that. So with regards to what the therapists address in the early stages, we see only a few impairment limitations to activities of daily living and their normal daily function. So the therapists at this point are looking for the fine motor problems, possible gait problems, balance problems, to where we can get in and do some early strategies and coping skills with regards to those movements. One more slide. So in this early stage, we are looking for what we can do with regards to, from a restorative aspect, we're trying to bring them back to that normalized movement to maintain or improve balance and gait. We want to work on core strengthening and developing a routine of exercise. One of the biggest things here we see is a lot of the patients start getting some apathy towards doing activities and exercises, and we want to instill at an early stage getting into a routine of activity and being as functional as possible for as long as possible.
This is also when, as a team approach, we decide on who's best to go in first. So depending on their level of involvement, apathy, depending on how the disease starts to manifest, maybe it's speech therapy that goes in and tries to work on the mental aspect of everything, or is it worth the therapist going in and having more balance issues, where it's all the team going in and saying, hey, we have this patient, these are the characteristics of the disease for this person, who would be best suited for this person to start off the therapy. We don't all go in all at one time. That's just not how therapy works anymore. That used to be what it was, but right now it is who's the first person up. And so we take a team approach. We look at the patient holistically and say, who would benefit this person early on? And so making that distinction early is important, because that can set the tone for therapy. So if speech therapy goes in and says, okay, we're going to get the cognitive portion together so that you are ready to learn, that you are able to sequence the movements and understand exactly what's going on and prepare them for a lot of the training that OT and PT does, then you're going to have a more successful therapy environment and success in therapy, as opposed to, well, let's just have somebody go in and they're not ready for that therapy. So that's why the team is so important in this right now, especially in the early stages.
And it's one of the reasons too why we work as a group between the PT, OT, speech with the physicians and the other team members. We want to hear from the families from the get-go what they're seeing as the issue so that we can always establish that baseline of where the patient is, and address some of those issues with regards to things like fall prevention activities, working to establish a baseline for the patient, recommending environmental modifications and long-term projects. We want to get those things from the get-go, and even if they're small and minor at this point, the goal is to work as a coach from the get-go all the way through the presence of the disease. So one of the things that we try to work on is with regards to the goals in that early stage are to limit the decline or that progression and try to either improve the situation or maintain the level we're at. And so what our plan is in this early phase with regards to the goals may to be maybe to achieve continuing activities such as hobbies that you may like, working on things that are going to be meaningful for you to want to do and to continue doing, that are going to be something that's motivating at this point. Can you move it on one more slide? So things that we're looking at, such as hobbies, are things like gardening, dancing, aerobic activity, such as walking or hiking, stationary or recumbent bike, yoga, tai chi, aquatic exercise classes, or swimming. The reason why we look at some of these is because they're addressing the body as a whole. We're not looking at working out with heavy weights and gym equipment. The point here is, can we work on normalizing gait? Can we work on normalizing activities with regards to things that we do on an everyday basis?
And it's to also keep the person, one of the main things that I tell the patients that we have, stay who you are. This disease has a way of isolating people and their families. And so if you're still going out having those Tai Chi classes, if you're still going, continue being the person that you are. And our goal is that we teach you to minimize the stress that you have with all of the things that are happening to your body. But that doesn't mean that you stay in house and you stay isolated to yourself. Go out and continue to be the person that you've always been, and do it for as long as you possibly can. And our goal is to help you do that as safely as you possibly can.
The goal here is to stay as engaged as possible in everyday activities. So we want to keep those things that are normal to you and keep you doing what you enjoy. So things that we would also like to look at in goals in the early stages are working on things that are preventing other things happening, such as stretching to prevent muscle tightness, core strengthening with regards to eliminating the postural changes that we can see as things progress, especially the extensor muscles. Working with regards to keeping ourselves upright also helps from the speech standpoint, because when we get those limitations in posture, then we start limiting our breathing ability, our vocal projection. So this is how we work a lot with regards to as our team approach. When we try to look at doing it from both aspects, we work with PT, OT, and speech, and how we can achieve maximum potential for all services. We want to work on things such as balance, activities to challenge static and dynamic activities, because again, sometimes we get into those static positions, and that also limits things that we need to be doing for occupational therapy and speech therapy, not just from a PT standpoint. Frequent exercises, short duration, high impact, one-on-one in small groups, so that way we don't get so much frustration. And then proximal stabilization exercises, because again, we want to work on that posture and keeping our core strong. So other things we want to look at is training on strategies. We want to work on coordination skills, sensory awareness, safety, equilibrium challenging. We want to work on multitasking with gait. We want to work on task-specific training with regards to balance, both static and dynamic. Trust building with regards to within the family as well as caregivers as they're needed later down the line. Motivational strategies, de-escalation strategies, especially if we're starting to see some of those frustration and irritation issues. We want to work with the families and teaching the families de-escalating strategies so that they can pass them along as things progress to those caregivers. We want to work on elements with regards to getting equipment that may be needed in place early. This is just some of the things that you might want to start looking at from an early stage. If we start having coordination issues, things like button hooks, we want to look at equipment with regards to making things easier to eat. We want to start looking at things where we're eliminating the balance from a dynamic standpoint, from things like reaching down to pick things up and using a reacher instead of reaching with our hands. We want to look at minimizing loss of balance and things like dangerous areas in the home that could be a challenge if there's any balance issues, such as the shower, with things like seating arrangements and grab bars. Some of the other things we may want to look at are also innovative home exercise options, such as looking at things like where IT is taking us these days in virtual reality with regards to games and challenges that we can use to keep people motivated as something fun to do.
And as far as the virtual reality goes, one of the things that we looked at doing was when the disease progresses, still being able to go out virtually. If you were someone who loved to travel, you can walk down the streets of Italy. You can go into restaurants and shops and be submerged in those things and not feel so isolated in the home, but also having things to talk about. Because when we are at home for long periods of time, the things that you want to talk about, or the things that you did talk about because of all the things you did during the day outside of the home, become limited. And so you have a context in which to talk to your family and friends about, oh, I did this and I did that. So it's a full approach of making sure, number one, that it's functional. One of the things that we teach here is that we want you to be you as long as you possibly can. But all the goals and objectives that we use aren't just drill and practice. We put those things in for functionality. So playing games with your grandchildren, or with the spouse, or with the guys that come over, or your women's group that comes over, being able to talk about the things that you see on the screen here, we try to submerge or give you all the options that you possibly can have in order to stay as functionally and communicatively socialized as possible.
The goal here is to keep you engaged, and what's going to be fun to keep you engaged in the process. So with regards to the early stages of the goals we would like to work on in the home are things to start early with regards to dress in the environment, such as things like the shower chairs, removing throw rugs, things like that. Caregivers and family involvement with regards to the patient care, looking who are going to be those people and what is the plan for long-term care. Starting to talk about that from an early stage with regards to the progression of disease as it goes along. Provide quiet environments to learn and limit stimulus. Again, sometimes the more stimulus, then sometimes the irritability and frustration comes in because it's harder to concentrate and learn. We want to look at the expectations with regards to from the patient standpoint and the family standpoint, as they should be clear and direct on both ends. And then keep it to a minimum. Don't overwhelm, make it short sessions, not long sessions that are drawn out. Try to keep it simple so that it's much easier to finalize the goals. Other things we want to work at in the home is to keep it to one task at a time, like we discussed. We want to look at break daily activities down into simple steps. Don't get overwhelmed by giving multiple tasks at one time that need to be addressed. Repetition does help. However, if we can also, it's kind of like I like to say, see it, touch it, feel it. If we can write it down, if we can talk about it, if we can prioritize a list, that sometimes helps rather than making it feeling overwhelming. Practicing these activities before they decline so that they become rote to where they're learned. redirection, and what the family learn in redirection along with a caregiver, so that if those situations do come up as decline happens, that we can redirect with those repetition of changes. And we're learning them from early on as to how to redirect and refunction. So other things we want to look at too are establishing a consistent routine. You know, we all tend to like our routines, and not always do we like change. So this kind of goes for all of us. Keeping the answers to yes and no and limiting multiple choice questions, because sometimes that can be overwhelming when you're given 4 and 5 choices and you're trying to process each one. Jason will try to touch on a lot of that in just a minute. Using word association to aid information retrieval, using a teach back method for learning. That way we know that if they can repeat it back, we're on track. Addressing safety before it is required, looking at things around the home. What are those things, such as we talked about, throw rugs, can we remove them so they're not trip hazard, moving furniture, decluttering, things like that. So the goal here in the early stages of therapy is to improve endurance and stamina, maintain strength or improve strength, stability and posture. We want to maintain that as long as possible. Balance and gait, we want to normalize those and keep them good as much as possible. Core stability, respiratory system, and maintenance, because that's going to also affect the speech end of it as well. So this is where we try to collaborate a lot on some of these goals. Education with the family and caregivers and patients. We like to work together on that with speech and OT as well, so that we can do this and there's not a lot of overlap, but we're always moving forward. PT outlines the exercise programs as home exercises, the use of the gym and how functional it is for the patient, and then the frequency and the duration of the activities. So next we're looking at the middle stages, and this is where PT, speech, OT, and so forth become more and more involved. So we've started coaching in the early stage, and now we're moving to the middle stage. And here with regards to HD, and individuals lose the ability to work or drive. They may no longer be able to manage their own finances or perform household chores. This is where we're going to be starting to look at getting more and more assistance. They may not be able to eat or dress as easily as before. They may need issues or helping with regards to personal hygiene. They may need some assistance in the shower. Chorea may be more prominent at this point, and the patients may have more difficulty with involuntary movements and tasks. So here, with regards to the problems with swallowing, maybe starting to show up. Balance falls becoming more prevalent. Activities of daily living becoming a little bit more difficult. You may see some weight loss because of the increased activity with the chorea. So these are all things from a PT, OT, and speech we actually address, along with things like the nutritionist, the dietitian, the physician stepping in to help with these issues. Problem solving becomes more difficult because individuals cannot sequence or organize or prioritize information. So this can become very frustrating for the patient. And so this issue then develops into problems with regards to getting them to stay on task for exercises, wanting to participate, because it becomes more and more of a challenge. So the memory problems also step in here too, from the standpoint that when we're trying to teach them to do certain things, it also becomes a challenge because it's their ability to remember what you've taught them. So in the middle stage of HD, the individuals, with regards to, they see an increase in number of impairments limiting their daily activities, and that can be very frustrating. So we as therapists want to jump in and normalize as much as we can and try to return function. So you're starting to look at these movement disorders becoming more prominent, postural changes becoming more evident, stability becoming less. With regards to, there's also muscle weakness due to the fact that they're not wanting to get up and move around because they are falling and having those balance and gait issues.
This is also a part where it becomes extremely important that you start communicating the levels of frustration, the levels of difficulty, and what is exactly going on. So in these stages, it's important for family members, therapists, doctors to have an open line of communication. Tell me what's going on. A lot of what my patients tell me is that people start talking for me a lot more than, because this is where it starts getting difficult. The chorea starts affecting oral motor ability and breathing and being able to express themselves as efficiently as they once did. And so they stop talking and start talking, they stop talking more and more, and other people start talking for them. And it becomes more frustrating when it's their turn to talk and somebody automatically jumps in. And so that frustration starts to build, and we receive a lot of it. And I like to go in at this stage and just have them tell me everything that you haven't been able to say before. I tell my patients, I will not speak for you. I will not jump on your words. I will not say anything unless you give me the floor to say something or to finish your sentence. And this is where a lot of that frustration starts to die down, and then other therapies can go in because they have said, okay, Jason, this is what's going on. And I'll relay it to the team. Hey, this is what we want to do. This is how we approach this. This is also where, like Sandra said, everything that we did in the early stages starts to come into play. So all of the redirection, all of the teachings, hey, we have a game plan for this. We knew that this was coming. Now it's time to implement the things that we did in stage one and then go over it in detail. Remember when we talked about this, this is why we're doing this. And I like that we write things down, and we do have home programs where we can go, we refer back to, okay, remember when we did this, this is why we did it. And so, like Sandra said, seeing, hearing, tasting, touching, getting all of this, the senses involved helps, number one, to get it ground into the patient so that they understand it and they're able to give it back to you. But also that memory component is the important part. Will I remember to do the things that I practice with Sandra or Pam or any of the other therapists that we work with? And that makes therapy so much more efficient, because it's not, now I have to teach you at a level where it becomes more difficult for you to remember the steps. Getting us in early provides, okay, we can call on those things from the first stages, and everything is already in place.
Keeping the patient engaged is a big part of it. And one of the things that I tell them is that when they are starting to get frustrated, and at this point they may not be able to, you know, with regards to chorea, write as well as before. And so one of the things we talk about is even recording what they're wanting to say. They're having word finding problems or they're getting frustrated, even just to talk into some kind of device with regards to they can record what they want to express. Sometimes just the fact that they can speak about it freely and nobody's really listening, but they can play it to someone when they want to, has helped with a number of patients in this frustrating time. So we're now seeing presentation of issues such as things like the dystonia and chorea, and these are impairing abilities such as ambulation, the activities of daily living, and keeping their independence, which can be very frustrating for the patient. So from a therapy standpoint, we're wanting to work on minimizing, you know, the falls. We really can't prevent falls, but we can try to reduce them using, you know, fall prevention strategies, and maintaining safety during walking and during activities of daily living. So from a therapist standpoint, we're looking at restorative standpoint again. We are still encouraging continuing with activities as much as possible that they enjoy, their hobbies, maintaining mobility, being independent, being social, interacting, and doing as much as they can. Families encouraging them to do as much as they can rather than limiting them, trying to protect them from, you know, getting into difficulties, because then we tend to minimize their ability to socially interact. So we want to continue letting them to do what they can to work on core exercises to maintain their balance, functional transfers, keeping them safe, working on their skills to maintain that independence of daily living. So at this time, we're looking at to see if the therapist can address possible needs for assistive devices. This is where we're going to start having these come in, both from PTOT and the speech perspective. So we are looking at improving safety. We're wanting to make sure their environments modifications are starting to be put in place if they're not already starting to use some equipment. But actually looking is, do we need to start making modifications to the home so that we can keep them in the home long term? So we're improving and looking at long-term needs above and beyond where we are now and looking to the future at this point. So devices may include things that you may want to use now, but also things that we may want to have before we need them, such as wheelchairs, such as furniture changes, things like no-low seating, seating that tends to be higher, firmer, more supportive, shower chairs, tub benches, reachers, and putting them in place while we're still have a decent capacity for learning and we're not having as many memory problems as we would later down the line. So at this point, we want to keep moving, be safe, ambulating, walking, maintain function, promote quality of life. And we also want to work on those relaxation strategies. And hence, this is where speech is going to start jumping in more and more with these patients from the cognitive standpoint, as well as with regards to respiratory and other things. We're wanting to reinforce the awareness of the new issues and address them. We want to look at functional training on transfers, exercise, balance, caregiver and family teaching. We want to look at those equipment needs and also equipment needs just not for now, but for the future. Those goals in the middle stage are to maintain as much as function as possible and to limit that decline. And we're still working on that restorative or maintenance aspect. So goals here we're looking at is balance activities to challenge static and dynamic balance and train on strategies to prevent or reduce falls. Equipment now, such as needs for consideration on helping with safety issues, adaptive equipment to increase independence, your shower chairs like we talked about, wheelchairs, even if they're not needed now, what wheelchairs we're going to need long term. And we want to look at future, not just present, because insurance will not pay for some of these things multiple times or in a short period of time unless there's an absolute need. So we want to look at what can address for long-term use. So some of the things now you're looking at starting to promote are things like dressing aids, looking at the grab bars, looking at a disabled height toilet or adjusting the height of the toilet or using it as an elevated seating, customizing chairs, not just off the shelf that are going to be appropriate for long-term use, modifications of bathrooms to where we're making things like the shower bigger or more accessible instead of having doors, roll-in showers or open areas. So here we are also wanting to address ways to make the home safer, decluttering like we talked about. We also want to look at unnecessary furniture. If there's a lot of ornaments sitting around that are easily broken, if somebody falls and knocks them down, those are things that we want to remove. We want to put anti-slip mats in the bathtub. We want to look at grab bars, even lighting. Because again, with regards to at night and things like that, if you're already having difficulty moving around, we want to use things like night lights and so forth to illuminate dark hallways, even to give direction. I had one patient who was pretty ingenious. She had green lights going one direction in the hallway, blue lights going the other. So she knew when she saw the blue lights, she was going towards her bedroom. When she saw the green lights, she was going towards the bathroom. Pretty good way with regards to being able to follow the way around the house, even if the area is dark. Using heavyweight, durable furniture. We don't want a lot of lightweight furniture because, again, if we're using it to walk or furniture walk around the home because it is tight and we can't get a walker or a wheelchair around there, then we're having something that's substantial to hold on to. We want to help to decrease stress and depression by exercising indoor and outdoor. And being outdoors can be very positive for the patient with regards to getting out in the sun in the daylight. We want to look at learning relaxation skills and to help with anxiety, because at this point anxieties can increase as they're seeing independence decrease. We're looking at good seating, so that's something with a good, firm, supportive back as well as seating. And that doesn't mean that it has to be a wooden seat or a hard seat. What we mean by firm seating surfaces is that there is a firm support underneath. It still can have pillows on it, but it will have a firm seating surface underneath to give them better posture, core control, balance. We want to look at removing items such as, like we talked about, decorations around the home, things that are easy broken. We don't want to have a lot of glass tables that if they fall and break, they can get injured. So we want to look at what can we do to improve that environment. So in this late stage, individuals require more assistance. We're heading into the stage now where we're looking at function has been quite fairly severely hit. So we're looking at activities of daily living to where it's fairly limited. We're looking at functional mobility may be fairly limited. We are finding now that these patients may be losing their ability to verbalize or may be nonverbal or bedridden in this end stage. So it's important to note that these patients seem to retain comprehension. So we need to consider that. Chorea may be severe at this point. So more things we need to look at are replacing, it's replacing the chorea more with rigidity, dystonia, and bradykinesia. So limiting that ability to move at all, at least functionally, is quite often seen. So we notice postural changes may lead to other problems such as the respiratory system, skin breakdown. Limiting in movement also decreases the ability for the skin to heal, because if we're not pressure relieving, then it's more likely to cause skin problems such as wounds formation. So we need to keep these people as functional even in this late stages, or have them transition, move, transfer, change location, even if it is a struggle. So we want to look at most of the exercises here either being range of motion, postural changes, looking at how we can maintain skin integrity, looking at the medical equipment and needs to arise at this time. So we're looking at things like possibly suction devices, because saliva management and things like that may be a struggle. We're wanting to work on posture so we can maximize their ability to be able to manage secretions and things. So again, the seating system, the wheelchair, the appropriateness of the wheelchair for positioning and comfort is huge. So from a psychiatric standpoint, we're also starting to see more issues with regards to difficulties with communication, which can lead to anxiety, depression, and this can also lead to frustration, irritability, and then emotional outbreaks. So we can have issues there that we're needing to put those strategies we learned earlier into use. Goals here with regards to the therapy in this late stage is to limit the impact of the complications arising from the disease progression rather than anything else. And so we're wanting to minimize further decline in other areas, such as comorbidities. So equipment needs now need to be considered from to help, and from a safety standpoint, not just from the patient, but to help the family members cope. We're looking at things like Hoyer lifts. We're looking at roll-in shower chairs, specialty wheelchair options. We may want to look and consider respite for the families, because this is now a full-time total care, quite often, job. And that can be very overwhelming for the families too. And they are your best advocate for the patient. So they need to be considered and be healthy too. So equipment at this point we're looking at are more specialty chairs. We may be looking at something like an electric or power chair. We may be looking at something along the lines of a tilt and space chair to help manage some of the chorea and the tone. We may be looking at things like almost like Lazy Susan type seating for the car to be able to turn and get them in and out of the car easier rather than struggle. We may be also looking at things like the shower chair, to where those modifications we made earlier in the mid-range are not coming into play, because we're actually having to roll them in the shower chair to the shower. So in this late stage, we're looking at patient safety, fall avoidance, and interventions. We're looking at adapting the living environment, establishing a routine that works for now and also for all, including the caregivers, support team, and then also respite care considerations for the family. some of the things that we have looked at with regards to, did a little evidence here on therapy and things like that for patients from all aspects, from early to late stages. So therapeutic use of music and dance, like we talked about earlier, for that balance and for working on coordination and normalizing movement is great. And so this is one of the things that we wanted to bring to the table, because people automatically assume, well, if there's a balance issue, we shouldn't be doing things like dancing, when actually dancing is a great option.
Absolutely.
So, you know, you see the benefits of the music and dance, because these patients do work really well with rhythms. And, you know, particularly important for a disease that, you know, doesn't have a cure, is to let them have some fun, let them enjoy what they really do. So there's art forms with regards to here, to where some of this comes into the cognitive aspect, the psychiatric aspect, and the psychosocial motor that addresses the neuroanatomy domains as well. And so there's preliminary evidence here warning that it wants a further investigation, because this is a really good option for patients. Moving on, one more. So in here, we also looked at, with regards to exercise in HD and mixed methods of how we can do therapy with music, and then the auditory cueing as well, synthesizing evidence here with regards to a positive impact on symptoms, such as things like the chorea, the bradykinesia, because they're hearing that music and that rhythm, it actually helps a lot.
In addition to that, it's very good for memory or both long-term memory, bringing memories back to a time and place. I always like to have discussions about childhood and, you know, what was your favorite song when you got out of high school, or was the favorite song in high school, and then bring those and that type of music in while we're doing therapy, especially during teaching, because it helps lock in those things that we're trying to teach. If I play the song over and over and over again while we're doing these specific movements, while we're doing these specific tasks, playing it helps retrieve those memories from a happy place, number one. And then number two, it allows me to just access that a lot faster than asking, hey, do you remember what we talked about last time? No, just put the music on, start discussing it, and then transition into the task that we're asking them to do. So it's a very good for short-term memory, as well as bringing back long-term memories where we can discuss things of their past.
Some of the other stuff, if you just want to move on, some of the other things we looked at was some of the randomized studies of actually taking small scale studies with regards to gym-based exercise with HD patients. And so even with this, it showed that keeping them active in the gym had actual decent effects with regards to outcomes such as structured exercise programs and keeping them as functional and as active as possible. Can you move on to one more? So on this one, we're looking at, there was a control study also done with regards to exercise, again, small scale in a gym. And it also showed with regards to the fact that with this, there was pretty good improvement with regards to the small scale study, and they were wanting to look at larger scale studies. One of the things we were looking at too, you know, from an activity standpoint, some of the evidence talks about too, the fact that if we can keep these patients as functional as possible and multitasking with regards to their gait, cognition also slows down decline. However, if we just work on the cognitive aspect, the gait doesn't improve. So this is another reason for keeping them as functional as possible, as long as possible. Next thing we showed here was some middle stage stuff too with regards to exercise programs and how that had impacted the patient with regards to a study over a 9-month on a small cohort of patients. And it too showed in the early and mid stages that keeping these people active and exercising was a huge part of helping them with regards to the disease process. So what I wanted to do is just throw some references in there, and those are things we can look at and that we used here in the talk. And I'm going to turn over now speech therapy and let Jason do his part.
Thank you. The great thing about working on a team like this is that you know, number one, there's a lot of carryover. And so with our patients, because they know Sandra or they know Pam or they know Wes or they know myself, we can refer back to, I know how our team works and I know what they teach. And so I know that you've learned, you know, X, Y, Z. So let's use that and bring it in for the speech part of it. And so you'll see a lot of what I have on my slides are exactly what Sandra was talking about. So we'll go through those parts pretty quickly. The parts that we'll stick on are the teaching parts where we're talking about the cognitive aspect, the swallowing aspect. And so, yeah, born and raised in Waterloo, Iowa. So I'm a northern kid. Went to school in Iowa, traveled around the Midwest, Northeast, and did different things there. Started working with pediatrics initially and transitioned into adults as my primary focus. But I've worked in almost every location that you can work in as a speech therapist. So I really love what I do. All right, let's get into it. So we've already talked about what Huntington's disease is. So all the things that Sandra talked about, the chorea, the gait, the cognitive decline, behavioral issues, we also deal with in speech therapy. And this is where the team approach comes into play. You know, Sandra asked me, hey, Jason, what should we do about, you know, the breathing aspect when we're trying to do some floor exercises, or I'm seeing some difficulty with, you know, they take a break, they swallow, you know, have their medications or have something to drink. And I noticed, you know, these things happening. So the hyperkinetic movement, the bradykinetic movements, those all come into play, not only with big movements with arms and legs, but a lot of the breathing and speech aspects as well. Let's move forward. So in the early stages, as we talked about before, we see deficits with attention and difficulty sequencing, decline in safety awareness, decline in difficulty multitasking. In late stages, that's where the dementia starts to come in, difficulty learning new motor tasks. Again, speech and OT, PT, SD all come into play as a cohesive group in making sure that even in the later stages, we're able to maintain the patient's safety. And that's the most important part for us. The difficulty learning new processes. So in early stages, my job is to teach strategies. So everything that we're doing, sometimes they send me in early to say, okay, these are the things that we need to work on. These are what we're going to participate in. Later on, you're going to do occupational therapy. Later on, you're going to do physical therapy. And so being able to make sure that they're able to follow one-step directions, two-step directions, three-step directions, and their accuracy in doing so. I give them strategies on remembering those things. Focus and attention aren't talked about enough for memory. People think they should just remember things. No, you need to focus on those things and attend to them so that they can get into short-term memory, so they can get into long-term memory, so that you can access them. So developing prompting sequences for caregivers, I tell the patient as well as the caregiver, my job is to teach you to be the best speech therapist that you can, so that you can do it when I'm not in the room with you. So I'm teaching both the caregiver and the patient on a lot of the sequences that they're going to need to be able to use together in order to travel through this stage, the stages of Huntington's. And the educational part for me is always the most important, because I tell people all the time, lead with education, and then it motivates you to continue, whether you agree or disagree. You understand what we're doing here. And so the great thing about working with Sandra and a team like this is that the educational aspect is paramount. I'm not going to just take you through range of motion. I'm not going to just tell you this is what you should be eating and you don't understand why you're doing it. A lot of patients come to us saying, well, I've never been told why I'm doing what I'm doing, so I don't follow through. Well, if I teach you why you're doing what you're doing, the probability that you're going to continue doing this, whether I'm here or not, goes through the roof, because you understand that there's a benefit to how I stand, to what I'm eating, to, you know, being able to go out, continue that boxing class, continue doing karate, continue going and doing lunch with, you know, the group of people that you continue to go out with. So developing open communication in this early stage is important, because we want to make sure that if you're feeling if you're feeling frustrated, if there's something that's in pain that's not being addressed, if the medications you think are not appropriate for you, let that be known early instead of having that frustration build and build and build and build. And now you're getting to a point where you can't express it, and now there's explosions all over the place, and your behavior is something that is hard to manage because you didn't release that valve early. And so my job early on is, listen, if you have something to say, say it. Don't keep that bottled in. And in learning to talk about those things with your caregiver, because your dynamic in your relationship is going to change. And that has to be in the forefront. You need to talk about it. So it's always speech therapy, of course, talk. I can't know what you're thinking unless you tell me what's going on. I can't tell the rest of the team what to address if you don't tell me what's going on. Short-term memory tasks with and without delays so that you can, hey, go get the brush off of the sink, or don't forget to put the top back on the toothpaste. You know, those little things that just annoy your partner. What did I just tell you? And that's not being facetious. It is, I want to know how long your memory is, because that helps the caregiver. I can't just tell you one time. I need to maybe repeat it a couple times. Hey, Sandra, what did I just say? And then, are you able to tell me what I just said? And a lot of the times I have a lot of laughing on that session where we're working on that, because everybody stops being able to repeat what I've said because you're not paying attention. And what I teach in that first stage is, hey, get their attention, because people just start talking and they don't know that you're talking to them because they're in their head doing something else. Well, I just told you, why didn't you? Well, I didn't know you were talking to them. So also, this is the stage where we use smart technology devices. Use your Kindle, use your television, use your remotes, use all these things on the screen, make life easier for everyone, but especially you need to take your medicine. Hey, Alexa, set a timer every day at 4, 12, 8 to take my medication. Tell Google the same thing. So cognitive games, puzzles, recipes, all those things that keep your brain working are the things that I teach in this first stage. Number one, it gives you something to do. A lot of my patients, their families, and their caregivers say, well, they just sit there. Okay, well, what do they have to do? What should they be doing?
Keeping people engaged is our biggest thing. We want to keep everybody as engaged as possible and have them buy in to what you're doing. And the buy-in is huge.
So the other important things that I want people to pay attention is, as this disease progresses, you won't be able to speak. You won't be able to have those conversations. Just go back one, please. It is about giving yourself to the generations that won't be there for you. So autobiographies are big for me. You know, write down your history. Not big for the people who are here, but your grandchildren, your children, you know, they'll want to go back and look at the things that, you know, mom or dad used to do, what they like to do, why I like to do these things. Personal cookbooks where, you know, maybe you were the cook of that family and people want to continue using those things, scrapbooking. But one of the most important things here is that voice bank. I have a patient right now who has difficulty speaking, and his son told me one of the most of the thing I miss about my dad is his voice. I miss his voice. And it's not that his dad's not there. It's not that his dad can't make voice, but it's not consistent anymore. And so the voice bank, if you don't know about it, please do some research on that and just take a listen to what they have there so that you can continue giving your voice to your family. All right, let's proceed. So we talk about behavior, anger, irritability, disorganization, depression, all those things that you see there kind of perpetuate each other. I'm disorganized, so I'm frustrated. I'm irritable and I have anxiety, and those things kind of feed off of each other. And this is another reason why I have my patients discuss why you're upset, determine what those triggers are, let your loved ones know. I have patients in the past where I said, hey, if you wake up and you know that you're at an 8 right now, stay in bed. Tell your loved ones, hey, I'm at an 8 right now. Anything right now can send me to a 10, and I don't want to get there. But you have to let people know. People don't automatically know. Maybe you were somebody who just, did things quickly. And so people don't recognize that you're irritable right now, that there's something going on with you. You have to let them know. But as caregivers, we need to know what those triggers are as well. I can't just keep saying, hey, Sandra, hey, Sandra, 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 hey, Sandra. Okay, now I'm at that 8. Now I'm at a 10. Now we're arguing. Now we're having to separate ourselves. But we could have avoided that. And that's not something that couples that have been together a long time do. They're used to having those confrontations and being able to move from it. But now I can't. And now I'm holding on to that because now maybe I'm having difficulty with those, the ability to communicate, while what you just did frustrated me and this is why. So we need to be able to have a open, honest conversation about what's going on here and be able to move from those behaviors and avoid some of those behaviors by confronting them up front. So how can speech therapy help? Educating the patients and caregivers on reasons for the behaviors. A lot of the times, caregivers don't understand why these behaviors are happening. Even the patients, I don't know why I feel like this. That's one of the most communicated things to me is, I don't know why this is happening. I don't know why. I don't know why. And so that becomes anxiety for me. That becomes a reason for depression. That becomes a reason to isolate themselves. I don't want to talk bad to my family. I don't want to have these explosions in public. I don't want to embarrass the people that I'm with. And so it's getting those things out in the open. And again, going back to that education standpoint, we start talking about verbal problem solving. Let's talk through what happened the instance that you just told me about. Let's talk about what just happened. Can you break down for me what happened? So verbal problem solving, having them tell you what happened and why those things happened. Developing productive communication behaviors. Even if you're saying, hey, not right now. And your partner having to be good with, not right now. Come back to me in 5-10 minutes. Hey, how are you feeling right now? Getting a temperature in the room as to how you're doing right now. Are you able to handle what I'm going to ask of you? Even something as simple as put the top back on the toothpaste. Boom, now you're an explosive. Okay, we have to figure out a way to communicate again. It's a different level of communication. Learning how to de-escalate once behavior has been initiated. That's huge for a lot of our clients. And being able to say, okay, how do we walk this back? And them letting us know how to do that. But that's educating everybody in the home, caregivers, spouses, children, family members. We need to know that there's a different level of communication that needs to happen now. So let's transition into one of the things that I work with most, especially with Huntington's, which is eating and swallowing. So dysphagia, talking about the international dysphagia diet, hyperkinetic movements, rigid bradykinetic, all these things come into play when we start talking about eating and the difficulty of eating. So dysphagia, simply put, is the difficulty or discomfort in swallowing as symptoms of a disease. And so the classification of dysphagia relates to the location, which includes oral dysphagia, oropharyngeal dysphagia, esophageal dysphagia, esophageal gastric dysphagia, and paraesophageal dysphagia. Can we move on? A couple slides. Yeah, so we're talking about diet now. So the International Diet Standard Initiative came about a couple years ago, and it's all to make sure that everybody is on the same page. So when we were in school, let's go one more slide. When we were in school, we talked about the food pyramid, and this is kind of what this looks like now. So whether you're in home health or you're in the hospital, this is a standardized way of naming and describing textures that you will be eating. So a normal diet, everything that you and I eat right now, growing up into the early stages of Huntington's is regular. So that's a 7. Water is thin, so that's a 0. But as we start to modify, which a lot of patients start doing on their own and they don't recognize, is that their food starts to get softer because eating and chewing becomes more difficult as the kinesias start to come into play. And so you start going to, bite-sized food. So you're looking at, meatloaf, which is easier than a steak. You start looking at mashed potatoes because it's easier than rice. You start looking at just modifying your food so that, number one, you can maintain a peel or by mouth diet instead of going to something that is an alternate means of feeding. And we'll get into that in a little bit. So with the hyperkinetic movements, chorea, swallowing incoordination, prolonged laryngeal elevation, all these things make it difficult to swallow and chew so that you don't penetrate or aspirate the foods and liquids that we're trying to eat. So we do oral motor exercises, we do laryngeal exercises. I teach on what it's supposed to look like, feel like, through every aspect, from the oral phase to the laryngeal phase to the esophageal phase. Everything is, I need you to know what you're doing and why you're doing it. So everything that you see on the screen makes it very difficult for patients to eat and drink. Let's go on to the next one. So aspiration versus penetration. Aspiration is food or liquid simply going into the airway and below the vocal folds. Penetration is getting into the airway above the vocal folds. And so your vocal folds are your first and last line of defense when it comes to swallowing. The fact that we speak is just a secondary byproduct of having vocal folds. Their job is primarily to make sure food and liquid don't get into the airway. So both aspiration and penetration should induce coughing. Both should cause food and or liquid to be expelled from the airway. Both can cause potentially a patient to gradually decrease their peel or bi-mouth intake. Both are reasons to have further testing completed. So when you start seeing someone who was a voracious eater, who loved food, who was a foodie, start to just back away from eating, there's something going on there, and we need to take a look at that and address it. Let's go into the next one. So swallowing anatomy, this is what we're looking at. There was another slide here that didn't get into this one. That's an easier one. This is what I'm used to looking at when we're looking at a modified barium swallow study. And so we're looking at the curvature of the spine. So again, OTPTS did come into play, that cervical spine of the pharynx that starts to curve, and that might modify how you swallow. The head positioning starts to go back, and the neck positioning starts to modify. Even anatomical changes start to move. You're moving, gravity starts to work against you. And so all these things come into play when we're discussing swallowing anatomy. And I go over all of this in therapy. I want you to understand exactly what's going on with your body. Let's go on to the next slide. So identifying dysphagia, very important for me. Declining appetite is something that happens gradually. And so I think a lot of people don't recognize it until, mom, dad, sister, brother, cousin just aren't eating much of anything at all. And it was a gradual decline, so they didn't recognize it. And so it's now you have massive weight loss, and there's an anxiety about eating because they know that it's difficulty, but they're not telling you that it's difficult. Coughing before, during, or after the swallow, eyes watering, nose running, changes in vocal quality. If they're sounding like they are talking to you from under the water, that's a red flag for me. If they have difficulty breathing while they're eating, that's a problem for me. If your eyes are watering and your nose is running, that means the food is going up towards the nose instead of down towards the esophagus, and that's tickling the back of the nose, and it's causing these other things to happen. Those are red flags. A lot of people have it their whole lives and they don't recognize that those things are actual signs of dysphagia. And there's some things that we can do to modify your behavior while you're eating that can eliminate a lot of these things in the early stages. And so we can mitigate those things in the middle and late stages. So determining severity of dysphagia. We do a bedside study. That's just me or the therapist sitting with you and eating. And we recognize, you know, that you are eating and you're chewing for, you know, 10, 15, 20, 30 seconds on a small bite of whether it's something that you don't even have to eat, like applesauce, or you have pasta or rice, and now you're you're starting to clear your throat, and you're starting to do a lot of sniffling, and you have a box of tissue that sits next to you at the table, and you go through a box every time you have something to eat or drink. And I'll say, well, we need to look at something further, because I only have certain pairs of x-ray glasses and they only work on Thursdays. So because of that, I can't see every time that something is going on. And so we refer you to a video fluoroscopy, a study of swallowing, or a fiber optic endoscopy or endoscopic evaluation of swallowing, or a modified barium swallow study, which is the most beneficial for me. The two in the middle are good for anatomical changes or something that is causing you to have difficulty swallowing. But a modified barium swallow study is you eating and having a video x-ray while you're eating, so I can see exactly what's going on. And in the next slide, hopefully it works, you'll see exactly what that looks like. Can you click on that for me? Let's see if that'll open up. So we use professional imaging. They come to the house. You don't have to go to the hospital, and everything comes to you. And you might have to share your other slide if that came up on another screen. But they come to you, they have a radiologist on standby. I mean, on the truck, they have a speech therapist on the truck. And this is what it looks like. Go ahead and play it, and I'll just hopefully talk over it. Hopefully it's not, let's see. Okay, so you can see that there's a lot of things going on. So pause it for me real quick. Thank you. So that picture that you just saw is a still shot of what this looks like. So you see the oral cavity, you see the bones of the neck, you see the front of the neck, which is a lot of anatomy that we won't go into right now because it's a lot. But you have food that literally goes from the lips all the way down into the neck. So this is what we could potentially see in the later stages of dementia and or Huntington's, where you have the inability to control the bolus or the food that goes in, and then you manipulate, you chew, and then the tongue brings it to the back of the mouth, and then you swallow everything all at once. Go ahead and continue to play it. So you see there's a lot of, so that went into the mouth, and you see that there's a lot of things that are going on there. So they're doing a lot of strategies. They're manipulating the tongue under the chin. They're doing a chin tuck. They're doing a lot of strategies that we go into, if necessary, to get the food to go down. And now you saw that they were able to swallow the food that was in the pharynx. So there's turning of the head. In this video, we're able to see there's a lot of strategies that can be used. Most of the time, swallowing is not this severe. So this is the severe of the severe. And so I wanted to show this because you do get to see a lot of the anatomy that we're looking at here. And I teach on all of this. I teach the caregiver, we go over the video, we go over the report. I want you to see why you're having difficulty. A lot of my patients will say, it's getting stuck right here. It's getting stuck right here. And a lot of the times they're 100% correct. There's anatomical changes that have caused that food or pills or something will pull in the vallecular or puriform sinuses down there, which are the two pockets that you see that are being filled with liquids. Those aren't in the airway. Now, there are penetration and aspiration in this, and I could show that, but we're running out of time here. We're going over, so I'll continue. So the importance of following exactly, identifying the severity it's not as observable on the bedside. It is about doing one of those studies that we just discussed, especially the modified barium swallow study. Silent aspirations occurs when the body's defenses no longer work, meaning there is no coughing or choking or any indication. So the nose stops running, the eyes stop watering, you're not clearing your throat, you're not coughing or choking. Aspiration pneumonia is the leading cause of death in HD, according to many studies that I looked at here, but that's just one that I put on here. Now, there are a lot of things that we can do to help and prevent a lot of the aspiration that happens. We teach on timing. We teach on carriers. So if you're having to take medications and they can't be crushed because there's a number that can't be crushed, then we use things like carriers. So pudding, applesauce, ice cream, yogurt. They keep everything as a cohesive bunch and they're able to swallow it and it's not just going all over the mouth. Also, thermal stimulation helps in that regard as well. So being able to have, number one, we do this, number two, we do that, number three, we do that, time of day, the spoon or fork or utensils that we're using, lighting in the room, how you place the food on the tray or the table or the plate. And then minimizing what we're doing while we're eating. A lot of our patients are so used to having the TV on over here or the iPad here, having conversation with somebody, having their AirPods in and having conversations while we're talking, while we're eating. No, we need to focus on one thing. And maybe we're getting to a point where 3 big meals are overwhelming. So we go down to smaller meals throughout the day. And so we make, a 2,000, 3,000, 3,500 calorie meal for the whole day. We divide that into 5 meals, 6 meals. So we go down to, saucer sized meals so the patient doesn't feel so overwhelmed. If you're having difficulty eating, a large plate of food is not something that you want to see. But I can eat a banana that's been chopped up already and some yogurt. I can eat, some ground meat and mashed potatoes. I can eat those things in smaller portions and I don't feel like everybody's waiting for me to finish this huge plate of food. And I know I can't do it, so I'm not going to do it. And then we start having other behaviors as a result of it. Head posture. So I talk to the occupational therapist, I talk to the physical therapist, and it's sometimes we talk about where the chair needs to be positioned because now we're in later stages. So having a chair that you can modify height and head positioning and all those come into play. Swallowing maneuvers. We talk about the Masako maneuver. We talk about the shaker maneuvers. We talk about supraglottic swallow. So we educate on literally every one of these things until we get to a point where it's no longer safe for you to eat by mouth. And if anyone has ever worked with me, that's my literally last option at all. So we do diet modifications from regular diet down to the puree, and I keep people eating as much as I possibly can. But there does come a time where it is just not safe. And the fact that swallowing aspiration is the #1 cause of death in HD, we have that discussion early, and we have a serious conversation that this has to happen. And so a peg placement is the last thing on there because that's my last alternative. I love for my patients to continue to eat. So let's go on. So as stated previously, we use a team approach. If I'm not the first one in the group, then we go to physical therapy because maybe balance and falling is the part that it needs to be addressed initially. If they see that, hey, Jason, they're not able to follow directions, and so we need some strategies, then I get in and I do that. And it's always a continuum. It's never, okay, speech is in, they're no longer back. They're no longer there. So maybe it's teaching strategies first, and then physical therapy and occupational therapy go in next. But then they start to see, okay, hey, Jason, they're starting to lose weight, or they're having difficulty swallowing or managing their pills. The family is saying that they're eating less. Okay, then I come back in. if I eat with them and they're finally able to, stabilize what they're able to eat, but they're having difficulty with access now. Now it's okay, now we need to get OT back. Now we need to figure out a placement for the chair. And so those are the times where we might have to coach people and say, okay, hey, this is what we need to look at. And we go back and forth and back and forth. And we try to make life as functional and as manageable as possible for not only the patient, but their caregivers. And so it's always teach first and then make it as functional as possible. Keep an open line of communication. All of my patients have my cell phone number, email addresses, and I tell them, listen, I gave it to you for a reason, use it. And I now have a group that we talk about books together via email. We talk about the latest movies that we've watched. We didn't get to a lot of the brain games that we play, but Happy Neuron and Lumosity and all those things. Hey, what was your last score on that? So even if I'm not in the picture therapy-wise, I still keep an open line of communication with my patients because I really want them to maintain that part of it. And a lot of it is, okay, I want you to be able to do this independently, but if I need your caregiver to simply set you up, then that's what we do. And so a lot of the things is like I said, it's a team approach and it's cohesive between sending an email or something to Dr. First saying, hey, listen, the medications, they're having difficulty with swallowing medications. We need a swallow study. I let the team know that, hey, the swallow study's coming in, but because of the falling that they're having done, I'm going to see them for just a week or two, teach on the swallowing, and then get PT back in. Once the falling has been minimized, then I come back in and maybe shore up any of the other things that need to happen. So always keeping communication open, making sure that we put the best therapy in first is always going to be paramount. And then it's always for patients and caregivers and staff, ask questions. So, if you don't understand the strategy, ask questions. If you don't understand why the medications that you're taking are doing whatever they're doing for you, ask questions, because if you don't ask the questions, you're not going to follow through. And you won't have the benefit of therapy that you could if you understood everything that you're doing in therapy. So to that end, does anyone have any questions?
Thank you so very much, Sandra and Jason. Your presentations were just fantastic, and so many, I think, helpful hints for all of us. So thank you. And again, we're just so grateful that you work with our patients and families, and thank you for sharing your knowledge today. And we'll be sure and share this link with folks that weren't able to join. So I think we have 5 minutes until 11:30, and we are honored to have Brenda Tapia here with us again today. And so I'll let Brenda go ahead and get started, and we'll go through a wellness exercise with Brenda. Thank you, Brenda, for joining us.
Thank you, Erin, for inviting me. Good morning, everyone. Today, as I mentioned on the very first session, my intention is sharing with you guys what I have learned from other teachers and different techniques different techniques that can help us on coping with the stress or overwhelm. In previous sessions, we practice meditation, and this time I want to share with you something that I incorporated in my own journey, and the technique is EFT. It's an old technique, and there is a lot of research, and I will let you do the research. We have only 5 minutes, and also because of the time, but also because I want to guide you today on having the experience of practicing EFT. What we do in this practice is that we work with our meridians, and while we work on them, it will send a sign to the amygdala, and it will calm our nervous system. The what the meridians, we are going to start working with the side of the hand, and then the eyes, side of the eyes, under the nose, under the mouth, collarbones, side of the arm, with under the arm, this level, and then top of the head. And when we start the EFT, we're going to focus on the negative emotions at the beginning, because I think in a short way to say it, whenever we want to wash the dishes, we got to see the dirt. If we don't see the dirt, it's hard to clean them. So we start identifying the emotion, the negative emotion, and then we work on that until we move into safe feeling or releasing of the emotion. The emotion that I picked today it is overwhelm. I think we all went or have gone through this emotion, and it's an emotion that it can block us in a way of identifying what is happening with us, that we are not moving forward, or what we are feeling or where we are experiencing that it's not allowing us moving forward. So you can turn off the microphones if you want to. You can turn off the camera if you don't feel comfortable following the meridians with the camera on. We'll guide you during the session. It's going to be a very short session, and you will repeat after me in your mind, or even loud voice if you prefer, with your microphone off. So we're going to start first on focusing on the emotion, overwhelm. Take a deep breath in, inhale, and exhale. And then tune into the emotion. Where do you feel it? In which part of your body? The chest, shoulders, the gut, the hips, the legs, or maybe the eyes. And once you identify the emotion and the part of the body that you feel it, rate the emotion from 0 to 10. Like at 10, I'm super overwhelmed. 0, I'm just super relaxed, and I don't have none overwhelm at all. And once you have raised the emotions, we're going to start with the side of the hand, and we start tapping the side of the hand. And you can repeat after me, even loud or in your mind. Even though I have this deep feeling of overwhelm, I truly love and accept myself. Even though I have this deep feeling of overwhelm and there is too much going on, I love and accept myself. Even though I have this feeling of overwhelm and I don't know what to do with it, I truly love and accept myself. Even though, one more time, even though I have this deep feeling of overwhelm and I have this feeling in, and you can mention the part of the body where you feel it. And I have this feeling of overwhelm in, you mention the part of the body. I truly love and accept myself. Now we're gonna move to the eyes area, the eyebrows. All these overwhelm, and you can repeat after me loud or even in your mind. All these overwhelm, there is too much going on. Side of the eye, there is too much going on. Under the eye, too much change. Under the nose, too much overwhelm. Under the mouth, and I feel it in my body. Collarbones, this overwhelm that I can't let it go. Under the arm, it feels heavy and it's stressing me out. Top of the head, this overwhelm that is making me feel stuck. Now we're going to move back to the eyebrows. We're going to move into the positive emotions. It is safe to relax. Side of the eye. What if I release this pattern of feeling overwhelmed? Under the eye. What if I tune my feelings and I release some of this overwhelm? Under the nose, releasing overwhelm. Under the mouth, when I release overwhelm, I can see with more clarity. Collarbone, when I release overwhelm, I feel more calm and it's easier to move forward. Under the arm, releasing overwhelm now. Top of the head, letting it go. Letting it go, overwhelm. And then when you stop tapping and take a deep breath, exhale. Then I want you to rate the intensity again of the overwhelmed feeling. Remember, 0 is I don't feel overwhelmed at all, 10 I feel super overwhelmed. Notice if you feel a difference. If you don't feel a difference, if you feel a little difference, you can repeat the practice until you reduce the intensity. This EFT practice, it can be used when any type of the emotions, or whenever, for example, you were explaining at the beginning in the previous presentation about eating, and sometimes when you start having difficulties on eating, it might the mind start making these channels of, in a way of protecting yourself, right? Because you start feeling these uncomfortable experiences after eating. So the mind creates these channels, and every time you're going to experience the nourishing your body, the mind reacts the channel, and the amygdala sends the signals, and your nervous system turns on. So a way of connecting with your nervous system is EFT. You can start doing tapping, like even though I feel stressed that I'm going to start to eat my food, I truly deeply love and accept myself, even though this feels very uncomfortable. I don't know, I'm going to feel uncomfortable after eating, or I'm going to shock if you're eating. I truly love and accept myself. And then you continue with all your meridians. So that will calm your nervous system, and that will allow you to see the experience in a different way, so you can take other decisions with more calm. And so there is plenty of data about EFDT. If you want me, I can send you some links, and I hope you found it useful. Thank you so much.
Thank you, Brenda. As always, that was lovely and therapeutic. And yes, if we would love for you to send us any information that you have, and we can share that with our families and our team. So thank you everyone for joining this morning. Thank you again to Sandra and Jason. Y'all were amazing, and then some, of course. We're so grateful, and thank you, Brenda, for talking us through that exercise. And I hope that we can use that on a regular basis. I think we can all benefit from these strategies. So I'd like to remind everyone that's in Houston that our walk is next weekend, and hopefully the weather will be nice, and we'll be together in person outside, which is great. So we hope to see you next weekend, and we will send out an email and let everyone know the timing for our final session once we hear back from Allison. So stay tuned. But thank you again, everyone. I hope you have a lovely weekend. Take care, and we'll see you soon. Hi. So good to see everybody. I miss everybody. Hi, Patrick.